خلاص طيب تمام.
Okay.
بس تأكد إن ليش ما نغطي الشاشة كاملة بس.
So we will start from where we stopped before the break. As I said, that if the patient comes to you complaining of troubling or bothering symptom of skeletal muscle tremor, okay, then you try to reduce the dose and use an alternative drug that might cause the same beneficial effect. And as we said, the class that's closely related to this function is the anticholinergic system. And there is one particular drug that's linked to the respiratory function, and that's Ipratropium. Okay? So we do not use atropine as a respiratory modulating drug. Let's take it away. Okay? That's a dirty drug. It targets all acetylcholine signaling within the body. Ipratropium is the drug that will act mainly on the respiratory system. Okay? As an anticholinergic drug, it will inhibit the M3 receptor. What's going to happen to calcium entry?
Decrease.
Less. What's going to happen to myosin light chain phosphorylation? Less. So the effect would be relaxation of the airway smoothness itself, so bronchodilation. Now, in practice, Ipratropium is a good alternative to SABA, right? If the patient cannot tolerate the side effects of SABA, then try to use the anticholinergic drug, Ipratropium. The other thing that's important to know about it is that Ipratropium is considered much more effective in COPD than SABA, okay? And there are multiple explanations for this effect. But let me say one thing. In COPD, the patients might have too much stuff going on their airways. Okay, the remodeling is much more worse with COPD than asthma. Okay, and there is much more mucus secretion and mucus gland hyperplasia and all of these. And such changes are more responsive to the anticholinergic drugs. And that's why Ipratropium is more effective. I don't care about the explanation, but just know Ipratropium is considered more effective in COPD than in asthma. What's the indication to use it in asthma? As an alternative to reduce or alternative to SABA once the patient cannot tolerate the side effects. Now, the good thing and the bad thing about it is that it has a slower onset of action compared to SABA. But not that slow. It's a slower onset of action. Okay? So, but still faster than blood. The side effects are almost minimal. You do not encounter too many side effects. And what they did, I don't know if it's available here in the journal or not, but what they did outside is that they started producing an inhaler that has both SABA plus an anticholinergic. Okay? And currently it's the most commonly used drug for asthma and COPD. It's called Combigan and it has both anticholinergic plus SABA. Okay? Alright. The final group or class of drugs that I personally consider as bronchodilators while others consider as anti-inflammatory are the modifiers.
دكتور بالكتاب مكتوب انه الاستما not progressive disease، ليش ما استخدم له long treatment؟
Asthma is not progressive?
It's
progressive in what sense?
بالchronic inflammation. انه الانفلاميشن فيها ما حيزيد، ما حيصير عندي exacerbations لبينكوت.
I doubt انه it's not a progressive disease، ولذلك البيشنت دائما ببلش ب intermittent asthma بينتهي ب persistent severe. Okay. What they meant, I guess, is the severity of chronic inflammation and the airway remodeling. Compared to COPD, no, there's not much progress. As I said, the remodeling in COPD is much worse, okay, and it progresses over time until the patient comes into a state where he does not have any lungs or airways, okay, and we will get to that in a minute. In asthma, that's not the case. The problem is the problem. There is not much worsening of remodeling, but I won't call it not progressive. There's remodeling and it's getting worse, but not as bad as COPD. Okay? But chronic inflammation is important causative factor along the way for both asthma and COPD. Okay. Methylxanthine. What's the common drug name you know? Theophylline. Okay. I consider as a bronchodilator because the major pathway we are targeting with inhaled or sustained release theophylline is something related to the contraction of the airways muscles. There are other effects, but with the inhaler kind or the oral kind of treatment we give for asthma patients, it does not get that function. The function is mostly bronchodilation. Okay? Now, theophylline currently is produced as sustained release drugs, sustained release drug, and it's important why? Because theophylline has a neurotherapeutic index, okay? Which means what? Between efficacy and toxicity, there is not too much space, okay? So, if you want to get an effect, if you just increase the dose a little bit, that might get toxic. Okay. So how are they going to deal with that? What they did is that, okay, let's not give too many doses and much have doses for these patients. Why not give them, for example, one dose, but with a sustained release of the active drug over time? Okay? It did not solve the problem totally, but at least there is much less frequency of toxicity with the sustained release preparation. Okay? Now, are the toxicities bad or very bad, severe? Actually, yes. And that's why theophylline is not encouraged in practice. Because if you get toxicities related to the central nervous system in the form of seizures, or in the cardiovascular system in the form of arrhythmias, then that drug sucks. Right? It's not that great. These are very serious effects, even worse than asthma itself. So that's why it's not particularly encouraged in practice. Finally, the other bad thing about theophylline is that it has several drug-drug interactions. I always like to try to focus on things you will use, and this is something you might not use at all. So why am I mentioning it? I'm mentioning it for the exam series. You can't imagine how many questions come on this. I have no idea why. I've never used it seriously. Prescribed it, or I work in the ER and I've never used it. Okay? But people always ask about it because there are lots of questions you might get. Okay? So it's worth it. Oral. ممكن كمان transdermal. حكم فيها release of the active ingredient according to the pH, for example, of your GI system, according to the presence of digestive enzyme. Yeah, it can be achieved. There's more. Okay. Now we get to the general, the chief of the drugs in this disease. It's the corticosteroids. And I'm trying here to focus on corticosteroids on several aspects of the corticosteroid use in the management of asthma and COPD because it's very important. So please try to follow me on the steps we're getting. Basically, the first thing to know is that the basic function of corticosteroids is double. First, to target the chronic inflammation, right, which is the major pathology in both asthma and COPD. Okay? If you inhibit inflammation, what's going to happen to airway remodeling? It will at least not get worse. Okay? You stop it there, and it does not get any worse. This is in the perfect life. Inhibit inflammation, which is the basic pathological mechanism, then the progressiveness of airway remodeling would be less. Okay? That's why it's very, very important. It's an anti-inflammatory and immunosuppressive agent, okay? And it targets the big devil in the pathology of both asthma and COPD. Because, and that's why it leads to an inhibition of airway structural remodeling, okay? Now, in all books, in all guidelines, from several years ago, this is what you find. Corticosteroids are the mainstay of long-term control. Okay? That's why I told you. The best drug is always the drug that will come and act on the basics, on the foundation of the problem. Okay? It's not always good to treat from above. Always try to look from the bottom, the basis of the disease, and try to treat it. And that's why it's the mainstay of treatment. Now, I have 3 or 4 clinical correlates you have to know about corticosteroids and know it well. The first thing is the routes of administration, because we have at least 3 major routes of administration for corticosteroids in the treatment of asthma. Now, as you would expect, the principal one, the most important one, will be the inhalation route. Okay? Now, inhalation is the principal route for the chronic use. Once you decide, okay, it's time to give corticosteroids, it's time to target the inflammation in these patients, then inhalation is your primary route. Okay? Now, what they found in recent studies, actually more than 50% of the patients might not respond to corticosteroids. And this was weird, okay? Given the fact that, okay, it targets inflammation, why is it not working? And a cohort study and a clinical trial study found that it was basically just poor technique of using the drug. Okay? So this is something you find always in guidelines. Educate your patient about the technique of using the drug. It's complex, actually. And the other thing that you need to know from a clinical point of view, I said inhalation route is great because it will reduce the side effects. Okay? But does that lead to no systemic side effects at all? No. And I asked you this question in the exam. Okay? You have to know that inhaled corticosteroids could still produce systemic side effects. The side effects we're going to discuss in a minute. They do not cancel or delete all these side effects. They might still happen. So take notice of that. Because if they do not happen, what should you do? Just give them like 15 to 20 puffs a day. Who cares? There will be no side effects. You're targeting inflammation. But that's not what we do. Okay? The second route of administration is the oral route. Okay? Now, oral route is a systemic route of administration for corticosteroids. So the percentage of side effects will be up, right? Because corticosteroids, if you want to know anything about it, it produces all the good things. At the same time, it produces all the bad things. When you want to treat a disease that you have no idea how it happens, give corticosteroids. Right? Seriously. For example, in dermatology, because they have no idea how things happen, they just give corticosteroids all the time. Okay? But at the same time, it just gives you all the side effects you might think of. And I don't know if I told you previously, in the 4th year internal medicine exam, the course admin will give me 10 indications, 10 contraindications, 10 side effects. Okay? But it's so. But if it causes all these side effects, why am I using it in the oral route? I use it only in severe uncontrolled cases. When the patient is not responding to inhaled corticosteroids, plus the LABA, there's no long-term control, he is progressively getting worse, then I might need to use a short course of oral corticosteroids because the effect will be much higher, right? So it's only in severe uncontrolled cases and for short term. Now once you give it you have to know that you cannot stop it all of a sudden. It has to be tapered down, okay? And as we said before, the main reason for that is that corticosteroids inhibit the hypothalamic, pituitary, adrenal axis if you give it exogenously. So if you stop it all of a sudden, what's going to happen to this axis? At least for a few weeks, there will be no corticosteroids, right? Which is bad for the body. And after that, there's going to be a burst of activity or a flare of activity after that. So it's bad. So you have to taper down the dose. But that's on the expense of high incidence of side effects. Finally, the injection, again, it's like the oral route. It's in the severe uncontrolled cases, but this in the ER-based therapy. Like in emergency conditions, you have an asthmatic patient, you want something quick, you might get corticosteroids by injection, and there is high incidence of side effects. Now, therapeutic strategy, I explained it before, and I'm going to explain it again. With the treatment of asthma using corticosteroids, we always start with something called a step-up strategy, okay? Which means what? First off, if you know that this drug is very effective, but at the same time it produces too many side effects, you have to be careful and cautious using it. And that's why you do not give it with maximum dose all of a sudden or at first exposure. You try to build it up. Maybe the patient will not need too high dose of corticosteroid. So we always start with a low dose and we reassess. If there's no effect, increase the dose. If there's no effect, increase the dose. Right? Now, if there is a step up, then there is always a step down. And that's why, because if the patient is responding well and his symptoms are much less, and the disease severity is much less after, for example, 3 to 6 months, then why keep him on a higher dose of corticosteroid? It's a bad drug, right? From the side effects perspective, right? It's a bad one. So what we do is step down if the patient is responding well to that therapy, okay? And finally, side effects, as I said, are something involving every single part of the body, but I wanted to focus on the things that have the highest incidence in these patients. Starting with morphology, you will have the moon face, okay? The second thing is hirsutism. I explained all of these. Central obesity, osteoporosis, and ulcer. These are some common side effects that happen with corticosteroids.
Hypertension.
Okay. Any questions before we get to the next? Did I give you or did I emphasize well that this is the mainstay of long-term control of both asthma and COPD? So you have to know lots of things about it. Okay. The next class are the Leukotriene modifiers. And as I said, it means that leukotrienes are mediators of inflammation, so that's why we need to suppress them. Again, if you look at the histology here, and there was a stimulus, any kind of stimulus for the occurrence of inflammation. These are the inflammatory cells, and they come out of the blood vessel, and what's going to happen is that they're going to be distributed all through the layer of the airways, including the media, the submucosa, and the mucosa, which means that they're going to have effects there. Now, what are these effects? Now, the first thing to know is that once an inflammatory cell is activated, one of the things that might happen is that the arachidonic acid, which is a component of the plasma membrane, any plasma membrane has arachidonic acid. During inflammation and activation of inflammatory cell, arachidonic acid will be degraded using one of the pathways is the 5-lipoxygenase, and that's going to lead to the production of leukotriene. Okay? If these are produced when the inflammatory cell is activated, then they play a role in inflammation. And this is the major function of them. Leukotrienes are secreted from the active cell, and they go even to further places within the tissue just to bind to their receptor, and they will get that cell into the air. So it's like what? It's like a call, a phone call. Hey, I need help. Okay? And this is chemotaxis, right? So the first function of leukotrienes is to recruit inflammatory cells to the site of injury. That's chemotaxis. The second thing that was found recently is that leukotrienes have receptors even on the smooth muscle. And once they are bound to these receptors, they will cause contraction. Okay? So mediators, leukotrienes are not only mediators of inflammation, but they also lead to bronchoconstriction. So is that fair enough to use it, or to use the antagonist in the treatment of asthma?
Yes.
Yes. It targets both things, the bronchoconstriction part and the inflammatory part. That's why leukotriene inhibitors, or pathway inhibitors, are good. We have two classes of these drugs. How could you inhibit leukotrienes? Give me options.
Inhibit receptors.
Receptor antagonists. What else?
5-lipoxygenase.
Exactly. So target the synthesizing enzyme. So we have the drug xyludin, which targets or inhibits 5-lipoxygenase, which leads to no production of leukotrienes, right? And the other thing we have are another class, mesanoleucus and monteleucus. Their function is different, or their action is different from xyludin in the fact that they are receptor antagonists. Okay? But in general, the net result would be less effect mediated by leukotriene. Now, going through all these slides, you will think, yeah, this is a great drug. Okay, so let's look in practice. Is it great or not? First, it's recommended for prophylaxis of asthma and COPD. So, prior to, for example, the allergic season, like you know that in the spring, asthmatic patients will have a miserable life. So what we do is that we give them a prophylactic regimen prior to spring. Okay? Why is that important? Because we are stopping one of the pathways that might be involved in the inflammation later on. Okay? So that's why they're good as prophylaxis prior to stimuli exposure. Now, the big advantage of leukotriene receptor antagonists and modifiers in general is that they achieve reductions in the corticosteroid doses. Now, as I said, in corticosteroids you have great effect, but you have also the side effect. Okay? We try to build up the dose, but sometimes we feel, okay, we got to like from a low dose corticosteroids into an intermediate dose of corticosteroids. There was no response. So you might think, okay, why not go to the high dose of corticosteroids, right? Some people say, no, this is bad, because you're going to get way too many side effects. So how can you manage that? They said, okay, instead of going up in the corticosteroids dose, no, use another drug that will achieve the anti-inflammatory function, and you don't need to go up in the corticosteroid dose, right? And this is the reported efficacy of LRTAs, or the leukotriene modifier. Okay? It's just that you do not need to go up with the dose of corticosteroids. You stop at a certain level and add them, and you will have an effect. But this is good. But at the same time, can you use them alone without corticosteroids? No. Okay? Because as I said before, leukotrienes are produced from active inflammatory cells. Right? So there should be inflammation. Once it's an active inflammation, leukotrienes will be produced. If you give it alone, you're not targeting the inflammation. You're targeting the propagation, right, of inflammation. If you want to target inflammation, then corticosteroids is your choice. So we can never use them alone. The recommendations, the guidelines, do not use these drugs alone. Use them in conjunction with steroids to reduce the dependence or the dose used with steroids. Extensively metabolized, this is something to know. And particularly in the liver, and that's why you always need to monitor the liver function test. Okay, and another something to know about them is that these drugs are not given to all ages. Like there is a drug that can be given after 1 year of age, another drug that can be given after 7 years of age, another drug that can be given after 12 years of age, which means there's some effect on the liver metabolism and the body response to the drug according to it. Okay. Now, 2 further classes, and we're going to be done. Starting with mast cell stabilizers. And as you remember yesterday, what I showed you is that mast cells could be activated if they express or if they have the IgE antibody on their surface. So once the IgE is there, if there is an allergen, what's going to happen? Exactly. The degranulation of the mast cell and the release of histamine and the function of histamine within the tissue. Right? Okay. What are mast cell stabilizers? In very simple terms, they just come here to this cell and inhibit the degranulation process. Now, how do they achieve this function? Let me tell you, nobody knows exactly. They talk about certain ion channels involved in the process, but the basic thing, mast cell stabilizers, they just inhibit the degranulation of mast cells. So there is less histamine involved. Okay. How great is that in the management of asthma? Or how effective? Is it going to be of great efficacy? Think. There's no answer. Okay, so it's one way to inhibit inflammation. But do you think it's going to be so effective just to take out steroids? Exactly. So mast cells are just one type of inflammatory. And histamine is just one type of mediators involved in inflammation. If you inhibit that, particularly in asthmatic patients, yeah, that's good. It's going to inhibit some sort of inflammation, but not the whole picture of inflammation. So that's why the efficacy of these drugs is not that great. Okay? They only target one part of the equation, which is the histamine release and the histamine effect on the respiratory tract. Now, we have 2 drugs, cromolyn sodium and metochromate. As you can see, it could be given as an inhaler or could be used also as oral solution. Now, the basic thing that you need to know is that these are just alternative. They're not preferred in the treatment of asthma. Okay? Yeah. When there's no effect of the primary drug you are using, you might use this kind of drugs as an alternative, but not for a long time, and do not expect great results. We are targeting only one single factor in the inflammatory process. But what was great about them is that, okay, this is my what was great about them is that they are poorly absorbed orally, okay, or in general, poorly absorbed, and that's why they have so very few side effects. When could this be an advantage? If they have almost very, very little side effects, they're going to be very safe to use in 2 categories we're always afraid of using drugs in. And these are children and pregnant women. Right? They have very few side effects, so they are safe, and that's why they are preferred over other kinds of treatments if you are dealing with an age group or a special case like the pregnancy, because of their safety profile. Okay? So in exams, if they tell you that a drug that's safe in children and pregnant women to be used as a first line in the long-term control, yes, you might have less sensitivity, okay, because of their safety profile. And finally, the good thing is balanced by bad thing. They have a short duration of action. And some books and some guidelines say they might be need, or you might need to take them about 4 to 6 times a day. Okay? So it's not great, and you might not have great compliance coverage. So the thing you need to remember, they are safe. And they could be used in children and pregnant. The last class, and this is something sophisticated and just introduced recently, and these are the anti-IgE drugs. What is the function of IgE in the process of inflammation or in allergy? As we explained yesterday, what I told you is that the mast cell has IgE receptors, right? Once an active B lymphocyte produces the IgEs, this IgE will go and bind to its receptor on the mast cell, right? And once it's bound, it's going to be a receptor for the allergen. And once the allergen is bound to the IgE, then the degranulation will happen. So you see the sequence? There is a stimulus coming down to this cell, the B lymphocyte. It's going to produce IgE. IgE is going to be excreted and will go and bind to its receptor on the mast cell, and it's going to be a receptor for allergens. And that's why, or this could be the trigger for degranulation of mast. Great. Now, the anti-IgE are monoclonal antibodies. They are recombinant, so there is some sophisticated way of synthesizing them. They just come and bind to the IgE receptor. So what's the advantage of them? Exactly. They will prevent IgE from binding to receptor. And why is that important? There would be no receptor for an allergen on mast cell. Why is that great? Because there would be no degranulation of histamine granules. Good? Okay, again, is that of great efficacy in asthma? Actually not. Okay? It's good. It's going to target one kind of, or one pathway involved in the inflammatory process, but it's not that great. Okay? So what we do currently, this is the drug that we have. It's called omalizumab. Okay? It took me a long time to memorize the name. What we use it in clinical practice is as an adjunctive therapy in poorly controlled, severe, persistent asthma. يعني لما تفلس. Okay? يعني لما الطبيب, there is no way the patient is getting severe, persistent asthma, poorly controlled, there is no response to anything. Okay, give them the anti-IgE. Okay? Now, why is it reserved for that condition only? Not only because it's not that effective, but because it's very expensive. Okay? And you're talking about hundreds of JDs to buy this drug. So if there is no great efficacy, why to pay all that money? And the insurance companies will not pay for it. Okay? Great. So this is the anti-IgE. Now, the side effects are injection related. Don't worry. I mean, if you give an injection, then you will have redness, itching, pain, infection. There's no direct side effect of the drug itself. Now, COPD is a largely progressive disease. Patients will get to a stage when they don't have any lungs or airways left. And I've seen it in many patients, okay, including my uncle. When I saw his last chest x-ray, it was terrible. There was nothing to look at, okay? It was all white. So one final step in the management of COPD is oxygen therapy, okay? This is something you will send your patient on at the very end stage, COPD, chronic bronchitis particularly, okay? They will take this to their homes. It's not a pleasant thing. Now, it's known that for most COPD patients, that they get into the respiratory clinic or COPD clinic carrying a cigarette, and they will come back or come out on an oxygen mask and attack. Okay? This is the natural history of COPD. Okay? You will get, or the patient, most of the patients will get to that point. Now, oxygen therapy is indicated in patients with end-stage COPD when there is respiratory failure. What do you mean by respiratory failure? The lungs are not functioning anymore. There is no gas exchange. There is too little of oxygen. There is too much of CO2 in your body. There is no respiration. Okay? This is respiratory failure. So you send your patient on oxygen. Okay? Now, the bad thing is that when they did cohort studies and trying to see the efficacy of the drug, the only regimen that was found to be effective in improving quality and survival is a continuous use of oxygen for 15 hours a day. That's the only thing. I mean, if you give it 10 hours, less than that, there's no efficacy at all. So the only way to improve survival, and the improvement in survival, by the way, is not that great. It's a few months, maybe a year at the most. Okay? So it's not that pleasant. Okay. The final thing I want to show you, this is not something you need to memorize or know. This is something you're going to study in your 4th year. It's a working model. You have an asthma patient. How do you manage them? How do you treat them? I'm going to give it to you in a sequential way. Now, most, or let's say that patients, newly diagnosed patients, will have something called intermittent asthma. Asthmatic symptoms that come and go every now and then. They're not that frequent, they're not that bothering the patient. What are you going to recommend?
Short-acting beta
Just the side. Short-acting upon symptoms. You do not use it regularly, as we said. There's no regular scheduling of SAL. You just take it PRN, okay, as required. Okay? Now, the thing is, because symptoms and signs and pathology of asthma is progressively worsening over time, lots of these patients will get into the persistent stage of the disease. Now, this persistent stage could be mild, could be moderate, and could be severe, according to the line. Okay? Now, if I want to start for a persistent but mild asthmatic patient, what should I add to them? Plus the side.
Corticosteroid, low dose.
What kind of corticosteroid?
Inhale.
Inhale. Never say corticosteroids, just say inhale corticosteroids. How do I start with corticosteroids? What kind of dose?
Low.
Low dose, because we want to step up. Okay? So be specific. The treatment in this mild progressive is the low dose of inhaled corticosteroids plus the short-acting beta agonist if needed, once needed, upon symptoms. Okay? Now, patients might come back to you in a few months, in a year or something. They're not responding that well. Okay, what's the next option you have?
LABA.
Exactly. So, LABA. Should I give it alone?
No, with corticosteroid.
So I will keep corticosteroids. Should I keep it as inhaled or give it as oral?
Inhale.
Inhaled. What kind of dose?
Moderate.
Well, now we start with 2 stages. The first stage is keep it as the low dose inhaled corticosteroids. You want to be very cautious, okay? But add LABA. That's going to be good for a symptomatic control plus a long-term control of the pathology. Now, the second stage, if the patient does not respond even after this addition of LABA, what are you going to do? Increase the dose of corticosteroids. But this time you're going to use a medium dose of inhaled corticosteroids plus LABA. I left a space here because we're going to see what's going to happen. Okay, so next, there's no response. What are you going to do? Okay, so the next step is giving a high dose, a step up. You see? Step up, low dose, medium dose, and high dose inhaled corticosteroids plus LABA. What if the patient came to you after 2 months and he said he's feeling much better, his symptoms are controlled? Exactly. You go down to the previous step. So this is a ladder. You start here, you go up, but at the same time you could go down. Okay? He came to you 6 months later and there's no improvement.
Leukotriene.
And you already gave them the highest dose of inhaled corticosteroids. What's next? As I said, Leukotriene modifiers, mast cell stabilizers are alternatives. They're not something to look at as the primary. Exactly. So that's the time we need the short course of oral corticosteroids. Okay? So the next step is start with a short course of oral corticosteroids plus what you already have. The high dose of inhaled corticosteroids plus LABA. After a while, the patient is feeling better. You want to stop oral corticosteroids. How should you stop it?
Gradually.
Gradually. Tap it down and go back to the step. Good response, go back and etc. Now, I left 2 spaces here because, as I said, there's first the role of the leukotriene receptor antagonists or leukotriene modifiers as, let me say, as an alternative to LABA in this case, in phase 4 or 3. Sometimes you do not want to use LABA for any kind of side effects or anything. So you might use the leukotriene receptor antagonist. No, wait, we cannot replace them. LABA functions as a symptom control. Leukotriene antagonist or modifier functions as an anti-inflammatory. So you're going to use it here just to reduce the dose or to prevent the increase in the dose of inhaled corticosteroid. So I made a mistake here and it's very important to know. LTRAs, the leukotriene modifiers, are not alternatives to LABA. Okay? These are symptomatic relievers, while these are long-term control. The final thing you have to know is the role of omalizumab or the anti-IgE. Patients severely or in severe persistent asthma, poorly controlled. There is no way you can go around the problem, and it's the allergy season. Just give them the omalizumab, at least if they have none. Okay? And see if there is any effect. I'm personally done. If you have any questions. Please.
Omalizumab by itself or additive?
Yeah, additive. So these, what I showed before, or these things, these are the principal treatments. You add omalizumab to see if there's any. Yes. Because of their safety profile, for children, for example, the pediatricians do not like to send the patients on a very high dose of corticosteroids or to even give them corticosteroids. So they might start with chromoline. Yes. You might try it and see if there is any improvement in children. Yes, LABA, you use it upon the mild to moderate resistant disease, okay? Just for the symptom control and also to reduce the dependence on corticosteroids. And to reduce also the dependence on the side. No question? This is the last time? Okay. Okay, the recommendations and the guidelines start with Leukotriene. If there is no response, go to the high dose. So the advantage of Leukotriene is to reduce the dependence or the increase in the corticosteroid.
As the end result of anti-IgE and mast cell stabilizers is to prevent the effect of histamine, why don't we go for antihistamine?
That's a good question. But antihistamines I mean, let me say that they are over-the-counter drugs. Do you expect them to be effective in treating asthma? Actually, not. Antihistamines will target, as we said yesterday, the histamine receptors on the airways, and they might produce this bronchodilation and all of that. But the efficacy is not that great. Okay? You might give it for symptoms accompanying asthma. For example, asthmatic patients are always prone to allergy. They might have allergic rhinitis during the spring, or during spring. During spring, they might have allergic rhinitis conjunctivitis. Then use antihistamine. There was one piece of news, I guess it was last month, for the Cromolyn, the Mast stabilizer. No, it was for Xylutine. The company wanted to have it as an over-the-counter medication in the States because it's very effective in the treatment of allergy, right? But it was rejected because the safety profile is not that great and because the efficacy is not that well documented. Please.
Is modifier safe for pregnant women?
Well, I asked myself this question yesterday, and what I found is that caution. You have to be cautious using the drug. That's a good question. Please. Yes, the answer is yes, and it's actually, if you take it from a pharmacological perspective, it's going to be the most effective, right? It's more effective than giving a beta-2 agonist. So it's reserved for cases when you are بمنطقة you don't have access to beta-2 agonists. Vijay Marir, he has an asthmatic attack and you have no drugs. Epinephrine is always there, use it. It's going to be an emergency condition for using epinephrine to produce bronchodilation. Okay, this is the last time I see you as second year medical students. Next time I see you, you're going to be third year. So, good luck.
طلعنيش